Okay, welcome back everybody. We are on to lecture 3 in our semester-long series of biomechanics here. So we've had an intro lecture and then one on kinetics, looking at force and how that plays a role in biomechanics. So now we're going to start jumping into the joints of the body, and I think this is what most people are excited about. It tends to be the information that I think most people, they find it's easy to apply it to what you're doing with seeing patients and clients. A little bit easier to see how it might apply. So we're going to just first today talk about human joints, human skeletal articulations, and then in the lectures coming up, then we'll jump into each section. So our first joint section after this one will be on the spine, and then we'll go into shoulder and elbow and upper and lower extremity. So first, let's talk about skeletal articulations in general. We want to look at the architecture, the mechanics, structural elements that are associated with our joints that affect how we move. We'll look at different pathologies, and then we'll look at the mechanics within joints, how they move, and how your anatomy affects movement. So, all right, so let's jump in here and look at this. So we first want to break joints down into their classifications, and the first classification we're going to look at are the synarthrodial or synarthroses. These are our immovable joints, and there's going to be two categories of them. So, we won't, as rehab or fitness practitioners, we won't do much with this type of joint because it's immovable. So the first one are sutures, which are the sutures in the skull. So if you look at the bones of the skull as they fuse when we're very young, it forms these sutures. So you can see here it shows, an example where you've got the parietal bone and the occipital bone, and then there are these sutures that join them together. And so really, if you talk to a neurosurgeon, a brain surgeon, these really don't move at all. You'll hear a craniosacral therapist sometimes talk about kind of moving these, and largely the science says that's probably not the case. But anyways, that's one. Within synarthrodial joints, there are sutures, which are immovable. And then we have, also within the same category, we have syndesmoses, which are these joints. They're bones that are joined together by a dense fibrous connective tissue. So this is an example between the radius and ulna is this mid-radial ulnar joint. And there's this really dense, almost like ligament. You might think of like your IT band, something like that, a really dense connective tissue that holds those bones together. So they're really not going to move. So again, two areas, syndesmoses and sutures, immovable, synarthrodial joints. It's the first classification. We're not going to do much with it. Surgeons would deal with these areas, right? If something is damaged and these areas are torn, maybe you tear this fibrous tissue between these bones, maybe it's something that would be repaired through surgery. Okay, and then we've got amphiarthrodial joints, which are slightly movable. So we're going from immovable, now we've got slightly movable. The first category here are called synchondroses, which if you know the base word con, that chondroses refers to cartilage. So this one here, the first one we have are where the ribs articulate with the sternum. So these are our sternocostal joints, and they have this thin layer of hyaline cartilage, which we'll talk about different types of cartilage, but this hyaline cartilage that joins the true and false ribs to the sternum, and it allows some mobility, right? So when you think about when we take a deep breath, our ribs will have different sort of biomechanics, and we'll talk about that in the spine section, but our upper ribs from our bottom ribs will move differently, but that movement partly is allowed by that amphiarthrodial joint on the anterior side of the thoracic cage. Also, even more so, our ribs hook into our spine, and back there we have more, the joints on the backside are movable, and so those two work together to allow our ribs to kind of lift and move and our thoracic cage to change, and which allows us to change the volume in our lungs and to breathe. So anyway, so that's one, synchondroses. And then we have symphyses, which also are amphiarthrodial joints, slightly movable. And a good one here you might think of is your pubic symphysis. So this disc, kind of disc type fibrocartilaginous disc right here that joins the two innominate bones. When you think about the pelvis, we have a right and a left innominate bone, and they connect at the SI joints in the back, and then they connect at this pubic symphysis anteriorly. Another symphysis is the joint between the discs in our spine and the bone. So if you think about, you've got one vertebrae and then a disc and another vertebrae. in between those where the bone touches the disc, that's also considered a symphysis. So those, just another category. Again, not an area we will tend to talk a lot about, talk a lot with people. They are moving a bit, but they don't tend to be in the movement practitioners sort of, it's not something we're targeting on a regular basis. Now, let's get into the ones that we will target a lot, which are diarthrodial or synovial joints. Most people are probably familiar with the term synovial. They're also technically referred to as diarthroses or diarthrodial joints, which means freely movable. They're characterized by certain things, which one is articular cartilage. So, we all talk about this, especially when we talk about the knee and the hip and people getting arthritis and maybe having joint replacements. We often are thinking about this articular cartilage, which is, if you've got the end of a bone, it's that thin layer, that protective layer that covers the bone, and this is a hyaline. It's called hyaline cartilage. It covers that bone. It's different than fibrocartilage. Again, we'll talk about those differences in each joint section, but just know that the first characteristic is articular cartilage to cover that bone and protect it. And then we have an articular capsule, which I often explain this to patients is sort of like a dense balloon, like a thick balloon that covers your movable joints. It holds in that joint fluid, right, your synovial fluid. So we'll have these on all of our freely movable joints, and I'll show a picture here in a second. They're really easy to see on certain joints like the shoulder, where you can actually, when you're dissecting, you have to kind of cut through the joint capsule to get to the joint. So you have that, this double layered membrane, a connective tissue structure. Sometimes we hear about people tearing their capsule, like in shoulder dislocations. Sometimes if somebody has an anterior shoulder dislocation, they might tear the capsule as the humeral head pops forward out of the socket. So you hear about capsule injuries in certain joints. Two other characteristics of synovial joints. We have synovial fluid. So this is this clear, slightly yellow fluid that helps to lubricate the inside of the articular capsule. It allows the joint surfaces to sort of move on top of each other with minimal friction. And then the last one are bursa. So we have these bursa, these small capsules that are designed really to help, again, reduce friction. They're filled with synovial fluid. They're sort of like a cushion, almost like a shock absorber in the joints too. And so we hear about bursitis, right? That's a term we hear a lot. Sometimes the bursa are thought to get sort of irritated and inflamed, and you can get bursitis. But we have them all over, and they help sort of cushion and reduce friction in our joints. So those are the four big characteristics. We're going to look at cartilage, articular cartilage, an articular capsule, synovial fluid, and bursa. Those are the four main characteristics that sort of are associated with diarthrodial or synovial joints. And I think I have an image here. Yeah, so here's, just one here from a cadaver looking at the shoulder joint. And you can see some of these things right here. Here's the articular capsule. This is on the shoulder. It's really easy to see on the bottom side of the joint. They call this the inferior recess. This on the shoulder, because the shoulder has such great mobility, we have this part of the capsule that kind of sort of droops down a little bit, which when we lift our arm overhead, the ball uses that extra space to allow us to get full range of motion. You can see the hyaline cartilage, this thin layer covering the bone. See that thin layer right on the outside there? What else we got? So then this would be filled, obviously, then with synovial fluid, and you can't see bursa on here, but they would be in various locations throughout. For instance, there'd be one right here. We talk about this one on the superior side. There's right underneath the acromion here is the supraspinatus muscle. And there's a bursa in here that helps sort of reduce pressure again and sort of shock absorb as the person reaches up overhead, and the ball of the humeral head here approximates the acromion. It sort of helps cushion the area and just kind of protect other structures. So, and again, just sort of an illustration of another joint, maybe something like the knee, or this could be even a finger, a finger joint based on the shape of the ends of the bone. But all of our synovial joints will have these characteristics. So anyways, just kind of some illustrations there, some visuals to help you think about those structures with synovial joints. And then Also, when we're thinking about synovial joints, we'll break them down into categories based on their mechanics and how they move. So one would be a gliding joint. Gliding joints are joints where we are thinking about two surfaces kind of moving parallel to each other. So we might think about it with the carpal bones, the two rows of carpal bones in the wrist. Those can kind of slide on each other. The facet joints in the spine kind of slide on each other and have a gliding type of they fit into this gliding category. We have hinge joints, so the elbow fits into a hinge joint category where it just basically allows one plane of motion, so flexion and extension, so that elbow joint is a good example of hinge. You might think of knee as a hinge, but your knee joint actually allows some rotation. It seems mostly like a hinge, but it's slightly different. We have a pivot joint. Pivot joint, the best one I think is up in the upper cervical spine, are C1, C2. So you have the C1 vertebrae and the C2 below, and they hook together via, there's a structure called the dens that they are allowed to rotate on each other. And so it's actually kind of cool, but about half of our neck normally gets about 80 degrees of rotation, and about half of that, 45 or so, comes from just that one joint in the neck, that pivot joint. So that is a true pivot. It allows a lot of rotation. Condyloid joints, the knee fits into a condyloid joint. Certain finger joints will fit into this, where they, like the knuckles on your hands fit into sort of a condyloid where they can move into flexion extension, but they also have this ability to rotate in other movements. The knee will often be classified in this because it has flexion extension, but then also when you flex your knee, it has internal and external rotation. So it's often described as a condyloid joint. A saddle joint, this one most commonly, the ankle sometimes will be talked about as a saddle joint, but the main one is the thumb. So this joint here, kind of deep in the thumb, it's called your CMC joint. It's a carpal metacarpal joint. So the long bone here is the metacarpal, and that hooks to a carpal bone, and right there is a saddle joint, and it allows for sort of a wide range of motion. You imagine our thumb can really do quite a bit. Our thumb is so important for opposition. It's its most important thing. The ability to touch the pads of our other fingers is what makes us unique as primates. So that saddle joint is really important. Interestingly, the saddle joint also is an area that is prone to osteoarthritis. So you can actually have joint replacements of that joint. You don't see them commonly, but it can happen. So that's a saddle joint. And then ball and socket. We all know the ball and socket. Mostly we think about our shoulder and our hip. The sternoclavicular joint, this joint right here where your clavicle hooks into your sternum, is actually a modified ball and socket, which is surprising to a lot of people. If you feel it and you move your arm, it moves quite a bit. But our true ball and sockets are our shoulder and our hip. And so just some illustrations of some of those. So here's the ball and socket. You can really think about the hip joint. The head of the femur makes a really nice ball, and then the socket is this deep concave structure on the acetabulum, and again, that can be replaced. It's an area that's prone to osteoarthritis. The condyloid joint here with the finger, right? So that was one I was talking about before. So the fingers have this sort of ability to almost sort of rotate, but also move through flexion extension. The elbow is a good example of a hinge joint, pretty much just moving in flexion extension. The saddle joint, again, here kind of has this interesting saddle shape, and here where trapezium, this carpal bone, hooks to the first metacarpal. This is, again, that carpal metacarpal joint, a CMC joint. This is considered a saddle joint. It gives us that wide range of motion. The pivot joint in the neck here between the C1 and C2 vertebrae, so the atlas and axis, they hook together with the dens, and it allows rotation. And then we have gliding joints, like I mentioned, in the carpal bone. So we have these two rows of little bones in the wrist, and those can slide on each other, and that creates a gliding motion where the surfaces are sort of just sliding on each other. So anyways, just some different categories. These are, again, they're all synovial diarthrodial joints. They all have a joint capsule, joint fluid, cartilage. So they're joints that we can target through exercise. We can mobilize them with manual therapy, and people specialize in these different areas. So you can dislocate these joints, so again, they're the type of joints we would spend most of our time on with clients and patients. Okay, so just some functions here, so we'll kind of jump out of structure and look at functions of articular cartilage. Articular cartilage is really important for, if you think back to that kinetics lecture, remember we talked about stress is force over area. So articular cartilage really helps to lessen stress on a joint by spreading the load over a wider area. So it's reducing contact stress, which means if you damage your cartilage and lose some of it, you lose some of your ability to spread load. So as people, maybe you injure a joint, maybe you injure your knee, like you tear your ACL in some traumatic accident, skiing or something. And that also maybe has some effects on the cartilage. Many people who have those injuries are prone to having early development of arthritis. So maybe in an injury like that, you injure the cartilage, and then that means that the loads you put on the joint moving forward are spread over a smaller area, so the contact stress goes up and it wears the joint out faster. So you lose the ability. It's so important. Cartilage is so important for spreading that load over a wider area. It also provides, that protective effect, but it also serves. It helps to reduce friction and lubricate. So articular cartilage in conjunction with synovial fluid, they're both working to reduce friction by lubricating the joint, which helps to obviously reduce wear and tear. Our joints are pretty amazing, really. They say that the amount of friction you have in your synovial joints is about 1/3 that of an ice skate on ice. So think about an ice skate, a hockey player or an ice skater. The skate on ice, our joints have 1/3 of the friction of a skate on ice. So our joints are amazing. I mean, the ability for them to just the degree to which they can slide and just how little friction there is, it's really an amazing system. And then articular fibrocartilage is a different area. So this is just sort of generally, when we talk about articular cartilage, again, we're referring to hyaline cartilage. That's what covers the ends of our bones in our synovial joints. But then we have these fibrocartilaginous structures like our meniscus. This picture is probably hard to tell what's happening here, but this is the knee has been cut in half on a cadaver. This is one I'm holding. And the femur's gone. So we're basically looking from top down at the top of the tibia. So inside the knee, this is where the ACL and PCL would have been cut. And these are our menisci, right? So we have the medial and lateral meniscus. And you can see there, we think about people having meniscus tears. The meniscus are really important. They're like the labrum in your shoulder and your hip. These are all fibrocartilaginous structures, and they help to deepen a joint. They make it deeper. They allow the articulating bones to fit together better, which means you're less likely to if you didn't have the meniscus in your knee, not only would the joint itself wear out faster, but you'd be more likely of dislocating your knee. It wouldn't be as stable. So the menisci form these sort of bowls, and when the femur sits down in there, the femoral condyles will fit down in these holes. They don't slip apart because they've got this little rim that kind of helps hold the knee together, and the ligaments and surrounding muscles. So they're a fibrocartilaginous structure. And just one example, the discs in our spine are fibrocartilaginous. Again, the labrum in the shoulder and the labrum in the hip. We have these little discs in our jaw, in our TMJ joint. The pubic symphysis I mentioned earlier, that is a disc. So you can find discs in fibrocartilaginous sort of structures in several areas throughout the body. Possible functions then of fibrocartilage, they help, again, like regular cartilage, to distribute loads. If you think about the meniscus, that meniscus helps to spread load. If you tear your meniscus and you have to have a piece cut out, you have a lessened ability to spread load. So part of the reason we really want to keep if you can, you want to preserve that meniscus and not have it removed. They improve the fit, like I said, so the joint congruency will refer to this. The two bones, everything, the joint fits together better with these fibrocartilaginous structures. So you can imagine those menisci and that sort of rim they form, that bowl shape on the tibial condyles, it helps to hold the femur in there and keep the knee together. They limit slip, so if you improve the congruency and the fit, the bones won't slip as much. Those two kind of hook together. And then if you limit the slip, that kind of play that's happening, if you limit that, you also protect the periphery of the joint because you're less likely to dislocate. If you dislocate and the bones come apart, then you're more likely to damage the joint capsule and other structures on the periphery of the joint. And again, help with lubricating the joint. So all these things, articular cartilage, articular fibrocartilage, synovial fluid, they're all going to kind of help lubricate the joint and reduce friction. And then shock absorbers. You know, your menisci, particularly the menisci and the discs in your spine, they are good shock absorbers too. So they a ton of functions here. I mean, again, just really pretty cool structures. So, and then what about connective tissues? So we've talked about cartilage here. We've had articular cartilage, articular fibrocartilage, connective tissues. Well, these are going to be tendons, which, you know, I'm often surprised how many times people mix up these definitions. So remember, you want to think of tendons as connecting muscles to bones. So our tendon is always taking a muscle and connecting it to a bone and helping us create torque to rotate our joints. So though we have those tendons, then we have ligaments that are connecting bone to bone, right? So the ACL, for example, is connecting the tibia to the femur. So it's connecting two bones, it's not connecting to a muscle or anything. And that's why we often think of ligaments as being passive structures, because they're connecting bones and we don't have voluntary control really of them. Whereas a tendon is connected to a muscle, which we have neuromuscular control of, so it's more of an active structure. So we'll talk about active and passive. The active structures, the neuromuscular system, is really where we as fitness and rehab professionals, that's what we work on with people. Surgeons work on the passive subsystem and active too, but they can target the passive subsystem through surgery. They can repair a ligament, a bone, those things that we can't really change directly with training. Obviously they will adapt with training, but you can't say, I'm going to do an exercise for your ACL. You can't work somebody's ACL and, you know, give them an exercise for their ACL. You can work things that protect it, but you can't directly target it like a surgeon can. Okay, joint stability. So let's talk a little bit about functional things here. So what is joint stability? It's just the ability from a definition standpoint to resist abnormal displacement of articulating bones. So if you have two bones coming together, right? So say you've got your femur and your tibia, and you've got all these structures that help those bones kind of stay centered on each other so that they don't move in an abnormal, excessive way on each other and damage, again, maybe damage the ligaments inside or the ligaments on the outside or other peripheral joint structures. So joint stability really is just being able to resist abnormal displacement of those two bones that are coming together, those two articulating bones. And we'll talk about different factors that contribute to this. So when we think about stability, we're going to really have three. This is probably one of the most important slides of the whole lecture, I think. This is something that can be really helpful to show to patients and clients to help them understand how we gain stability in our body. But we basically have these three subsystems. And so you can think of them as sort of active and passive. And this originally comes from an article by Punjabi that was originally designed to describe the spine, stability in the spine, but it really applies to all joints. So if you think about, you've got a neural subsystem, which includes your central nervous system and your peripheral nervous system. And then you've got a muscular subsystem, which includes muscles, tendons, fascia, and then an osteoligamentous system, which again, this is where surgeons can directly operate, us not so much. So this would be bony structures, the joint capsule ligaments, the discs in our spine. This osteoligamentous system, because we don't have direct voluntary control over it, is often called the passive subsystem. It's kind of along for the ride with these two. These two are the active subsystem. We have direct control over these through training, exercise, things like that, therapeutic movements. We can train the neuromuscular subsystem or the active subsystem, and by improving the active subsystem, that helps to improve stability. And then so these three are all working together to give us stability. If we tear a ligament, well, then we lose some of our stability. So this neuromuscular subsystem then has to compensate to make up for this change in the structure of the passive subsystem. So a surgeon can come in again and repair that and give us our stability back. Likewise, if we had some sort of neuromuscular disorder, well, we still have the ligaments and joint capsule and things giving us stability, but we are compromised if we have something going on here that diminishes our ability to use our muscles and tendons to contract and maintain stability. So the three are really working together, and again, I find it useful when people have particular injuries and discussing stability. Visually, it can be nice to see how these three work together. So I hope that's helpful to you. The neutral zone, this is again from the Punjabi articles and specific to the spine, but it also, again, can be applied to other joints. And basically, it's this area, we talk about this neutral zone, which is this area in this sort of the middle of a joint's movement where It's mainly controlled by neuromuscular elements. So in the spine, for instance, if you're standing up straight in sort of a neutral spine, that there's a small area into flexion and extension. So this is supposed to neutral, direct, pure neutral is this vertical line. On either side we have a flexion going to the right and extension going to the left, this full range of motion. Right in the middle here is an area where we don't get much stability from our ligaments, from the passive subsystem. So we're not getting much resistance from ligaments, the joint capsule, the bones. So it's really controlled by neuromuscular elements. So we refer to that as the neutral zone. So things like are in the spine, our transverse abdominis, multifidus, all of our muscles, trunk muscles, kind of help control that neutral zone. And then when we move out of that area, we get the elastic zone where ligaments and passive subsystem structures start to kick in. So again, you can apply this in other joints. You can think about there's this neutral area in a joint where it's really going to be controlled mostly by neuromuscular elements, and then when we move outside that and we start to put tension on other osteoligamentous structures, they will also help contribute to stability. So just another component of the passive and active subsystems and how they work, how we think about their function throughout our total range of motion. What factors increase joint stability? Well, things that reciprocate. If we have two bones that match well together, then we have a lot of stability. Maybe you would think of, let's think about a couple of joints that, how about our two ball and sockets? If you think about those two, which one do you think has more stability, the hip or the shoulder? Well, if you think about it just based on this definition, the hip. The hip, if you visualize the anatomy of the hip, it's a very deep socket. The bones fit together very well, and so you gain a lot of stability because of how well the femoral head sits in the acetabulum. It's a very deep socket, and then you have a labrum, you have all these strong ligaments. So the hip, just purely based on the shapes of the bones, reciprocates. The congruency is very high. They fit together really well. Where the shoulder also, there's some good fit there, but it's a much shallower joint. So the upside, right, is that we talk about this a lot of times, is that when you gain stability, you lose mobility. So if you think about the hip, very stable, not as mobile as the shoulder. Shoulder doesn't fit together as well. Tons of mobility, which we need for reaching overhead, feeding ourselves. It serves a functional purpose, but it also means the shoulder is less stable, which is why people dislocate their shoulders way more often than they dislocate their hips. Same type of joint, but you hear about shoulder dislocations much more frequently, and it's because you give up some stability to have that huge mobility, just that ability to move through that wide range of motion. So how well the bones fit together, a strong array of ligaments and tendons crossing the joint. Again, the hip is got really, there's just all these strong ligaments at the hip joint, surrounded by tons. You think of how powerful the glutes are. I mean, you've got your hip flexors, your abductors, adductors, internal and external rotator. I mean, the hip is just covered with stuff. The knee is another good example. It's, the knee, you've just got two bones kind of stacked on each other on this long lever, and it's pretty cool how stable the knee is. But, just super strong ligaments, lots of muscles and tendons, a strong joint capsule. So those things all work to increase joint stability. And then the absence of muscle fatigue. Again, thinking back to how important the neuromuscular system is, this always seems to be a factor in these traumatic joint injuries, right? Like the person skiing, they decide to go on one more run even though they're tired and they are fatigued, and it's always that last one that seems to get people. So you all probably have experienced that. If you've done a hard workout and your neuromuscular system is very fatigued, you might kind of feel like it's harder to control your joints, and so your risk of injury is greater because joint stability goes down when that neuromuscular system is very fatigued. Okay, joint mobility is the relative ranges of motion at a joint. This is typically measured with a goniometer. It's a tool that you may have seen. PTs use them a lot, and occupational therapists, where you can move the two arms and measure in degrees the joint range of motion. There are kind of cool apps out there you can use for certain joints nowadays. So the range of motion, so mobility. This also gets talked a lot about online. People. There seems to be a lot of discussion about what's mobility and what's flexibility and how are they different. So for the purposes of this, we're looking at the relative range of motion allowed at a joint. Mobility is the relative range of motion. This is how we tend to think about it in the rehab world, that mobility is thinking about joints. And you can have active and passive mobility. So you might have mobility where some practitioner is moving someone and they're just totally passive. And then you can have active mobility where you're using your musculature to move the joint, and then you'd be looking at, well, how far can that person move their joint through an active voluntary contraction. So mobility we're going to think about with joints. And then range of motion is, again, is that, you know, you're putting a value, a quantitative value on that movement, and there are whole courses in this on how you set people up, what your landmarks are. You have to know where to position a goniometer, but half the time you can just eyeball things and kind of see where people are at and compare side to side and kind of use that as your indicator of impairment. Is there an impairment there or not? So joint mobility, range of motion. This just sort of shows one example. There's actually a problem with this picture. I don't know if anybody can identify it, but we're trying to measure, in this example, hip flexion joint mobility. So here it shows one example of how you could position a goniometer. So one arm of the goniometer here would bisect the other leg, so bisect the femur, and then the moving arm of the goniometer would bisect the limb that you're moving and actually measuring. So we'd get this hip flexion measurement, and as you can see in this looks a little bit shy of 90 degrees. So, you know, maybe they're getting 80, 85 degrees or something like that, if 0 is the starting point down here. So can anybody identify the problem with this? If you wanted to measure hip flexion joint range of motion, what's the problem with this picture? If we wanted to know the mobility of the joint. Well, the problem here is that the knee is straight. So this isn't a good way to measure hip joint range of motion because the hamstrings are going to be the limiting factor. So this is really more like a flexibility measurement. It'd be like the sit to toe kind of reach that people do for for spine and hamstring flexibility to measure that, how far someone can move. But if you have someone's knee straight like this, you're putting the hamstrings on tension, so you really don't get a good idea of what the hip can do. And the hip is supposed to get 120 degrees of flexion, so the reason the person's stopping here is because their hamstrings are the limiting factor. So anyways, you have to think about that when you're measuring joints. You have to make sure that any muscles in the region are on slack. You can't have them on tension. So, and we'll talk about this in each joint section. This is called passive insufficiency. So if you take a muscle group like the hamstrings that cross the hip joint and the knee joint, and you put someone into hip flexion and knee extension, you're putting that muscle group on stretch at both joints, and that limits range of motion, and this is called passive insufficiency. So if you're measuring a joint, you have to make sure that the surrounding muscles aren't your limiting factor. Anyways, that's a tangent, but worth noting. So, okay, joint mobility. Okay, now, within joint mobility, we're going to start talking about some of the mechanics. So these are going to be broken into two categories, and osteokinematics is the first one. This is what most people are going to be familiar with. These are broad, larger movements that joints are able to do, and there will be things that, again, that you're all familiar with. They're bone-on-bone movements. They're referred to also as physiologic motion, and they include things like flexion, extension, external rotation, abduction, adduction. It's all those big bone-on-bone movements. So those, everybody's familiar with those. And then within those larger osteokinematic movements, we have arthrokinematics, which are bone-to-bone movements, and they are always accompanying the physiologic motion. These arthrokinematic motions form the basis for mobilization. So when PTs and chiropractors and occupational therapists and people in those professions are mobilizing someone's joint, we mobilize the joint based on these arthrokinematic patterns. So they are also referred to as accessory motion because when you move through a physiologic motion, these are accessory motions that accompany the physiologic motion, and they basically are thought to help keep the joint centered so that you don't dislocate or damage peripheral structure. So this is a pretty complex thing. I'm not expecting everybody to totally understand it by the end of this one, but we'll talk about it in each joint section, and it'll make better sense as we go along. So, and they are broken down into roll, glide, and spin. So the accessory arthrokinematic motions are roll, glide, and spin. We're not going to talk about spin a whole lot. It's basically clockwise or counterclockwise. we're going to mainly talk about roll and glide and what type of roll and glide you'll have in each physiologic motion. Okay, so arthrokinematics, just to break those three down. So roll basically refers to many points on one articulating surface coming in contact with many points on another surface. So imagine a tire rolling down the street. If you're driving your car, as your tire rolls, new points on the tire are meeting new points on the road, right? So that would be something rolling. Okay, so you think about it that way. Glide is something kind of sliding. So if you took your finger and slid it across your other hand, you have the same points on the finger meeting new points on your other hand. So that's a glide or a slide, just to break it down. And then a spin, you have specific points on one surface staying with specific points on another. So if you spin your finger on your hand, the same points are touching. It's just there's a rotation happening. And these three are all happening when we go through various physiologic motions. They just accompany our other larger movements, and we'll mainly talk about roll and glide. So for right now, just know the definitions. They'll come up again in each joint region. And this is a little bit of extra. This whole arthrokinematics section, if you go to physical therapy school, they'll teach this to you. They don't usually teach it in undergraduate biomechanics, but because of my background, I always like to bring it in. A lot of people who are watching this are interested in rehab and therapy-based professions, so it's nice to have it kind of early on in undergrad. If you go to graduate school, it'll help you understand it better when you get there. Okay, and within arthrokinematics, there's an important rule called the convex-concave rule, and this will help us understand this accessory motion, this arthrokinematic motion. We have to know which side of the joint we're on. All of our joints have a convex side, an outward-facing side, and a concave side. And those two fit together. All of our joints have a convex and a concave side that allows them to fit together. Some are more obvious than others. If you think about the hip, you have a really deep concave socket, and you have a very obvious convex femoral head that fits in there. Other joints aren't quite as obvious, but we will break each joint down into what's the convex side and which is the concave, and that will help you figure out what direction of roll and glide is happening in the joint. In terms of the rules, so we're just going to cover the rules right now, and again we'll get into specifics in each joint. The convex portion, the roll and glide, occur in opposite directions. So imagine if you have a joint, a bone that's rolling anteriorly, that means that the glide would be posterior. So they just occur in opposite directions. So if you have a convex joint, convex like an outward-facing joint, and it's rolling anteriorly, it's going to have an associated posterior glide. Those two working together help to keep the joint centered. On the other side, if you have a concave surface, they're going to go in the same direction. So if you have anterior roll, you're also going to have anterior glide. So they go together. To be honest, when most people learn this, the concave side is easier to figure out. You have to be able to mechanically visualize the architecture of the joint, know are you on the convex or the concave side, know this rule, and then you can figure out what pattern of movement is happening in it. So again, this is like probably super abstract if you've never had it before, so just hang in there and we'll get to it more in other sections. But you basically want to know there's this convex-concave rule and how each side of the joint, the convex, roll and glide are in opposite directions, the concave side, they're in the same direction. So just know that for right now, and then we'll talk about it more later. Okay, factors that influence joint mobility. We've got intervening bone, muscle tissue, fat, right? These things can limit range of motion. Probably the best example is knee flexion. So if you sit here right now and you try to bend your knee all the way, in most people, the thing that limits knee flexion is called soft tissue approximation. So it just basically means your calf and your hamstrings come together. So you don't actually get to the end position of the joint, it just stops because the muscles hit, the soft tissue hits. So there are some areas where there is this just naturally a soft tissue approximation. If you have really big elbow flexors, really big biceps, you'll see some people where they end up kind of hitting the soft tissue mass, not in my case. But anyways, that can be a limiting factor. Tightness or laxity in a muscle or connective tissue, collagenous tissue crossing a joint. So Especially in our two joint muscles, a muscle, they're called biarticular muscles if they cross two joints like the hamstrings. So like in that image before, if you take somebody and you have a two joint muscle and you have it on stretch at both joints, that can limit range of motion, just like we saw in that image. What's another good one? Another one would be the rectus femoris muscle in the quadriceps group. That muscle is a hip flexor and a knee extensor. So it can limit, if it's tight, it might limit how far you can get your leg behind you when your knee is bent. So these will come up in more examples, but obviously most of us know that tightness in a muscle could limit mobility. Muscle fatigue, right? So you may have limited mobility if you're fatigued and you can't actively pull something through full range of motion, right? Fatigue, we all know when we're tired, there can be times where it's hard to complete full range of motion, to move through full mobility because of fatigue. So yeah, that's another one. Techniques for increasing joint mobility of joint mobilization, and this is where a lot of, especially PTs and chiros, spend their time in terms of manual therapy. These are designed to obviously reduce pain, but also to improve joint mobility. It was often taught that they help to reduce capsular tightness, which probably still could be the case, but it seems to be more complex now, that there may be something more neurophysiological where the mobilization is stimulating the mechanoreceptors in the joint, and that helps, that the mobility change is more complicated than we once thought. These are graded on a 1 to 4, so if you think of the mobilizations where somebody's, like a manipulation where somebody's spine, a joint pops, that is a grade 5 mobilization. Sometimes it's called an adjustment, a manipulation. Sometimes it's called a thrust mobilization. It's got a quick, small amplitude movement, and it causes a joint to pop. But there are also mobilizations below that, grades 1 through 4, which are not popping the joint, and they're just sort of oscillating, kind of wiggling the joint. And this is what I end up doing most of the time with people, but they kind of help reduce pain and improve mobility. And 1 through 4, they have different characteristics. We won't jump into that, but just know they're out there. Again, grade 5 is referred to as a manipulation. Okay, so those are some ways to increase joint mobility. When we think about sensory receptors, this also, when you're thinking about improving joint mobility, we want to consider the muscle tendon unit, because we know muscle tightness can contribute to a lack of range of motion, and there are some sensory receptors in that musculotendinous unit that can be associated with your ability to sort of move through full range of motion. And one is the Golgi tendon organ, which is a sensory receptor that measures, basically, it looks at how much force is on the muscle tendon unit, how much load is on the system. And if you, for instance, were thinking about lifting a really heavy load with your biceps, the Golgi tendon organ would be in that musculotendinous unit for the biceps. And if it detected too much load to where you might damage the area, then it would inhibit tension. So if I'm squeezing my bicep and, it looks like I'm going to hurt that bicep tendon, then the Golgi tendon organ will cause me to relax. It will inhibit tension. So I will relax my bicep so that I don't damage it. And at the same time, I will tighten my tricep, the antagonist muscle. So it basically takes me away from that position that could damage the tendon. So it's basically taking load and force off of the tendon. And then the other one is called a muscle spindle. This has sort of a different, it's measuring stretch in the muscle. And so this is what we see when you have your reflexes tested. When somebody takes the reflex hammer and hits your knee and your leg kicks out, that is a muscle spindle reflex. So when you stretch a muscle and tendon really rapidly, because it's detecting such rapid stretch, because if we stretch something too far and too rapidly, it also could cause damage. So the response to that is, if something's stretching too quickly, your body will cause that muscle group to contract and take the stretch away. So the muscle contracts and shortens, which removes the stretch. So if you imagine a knee reflex, if I take the reflex hammer and hit your patellar tendon and your knee kicks out, when you hit the tendon, it causes a quick stretch. So your body's response is to cause the quads to contract and shorten the muscle and tendon to protect them. At the same time, we inhibit the hamstrings, because the hamstrings in that case would pull you into more stretch. So you basically have these two, muscle spindle and Golgi tendon organ. I have a table here that might make this a little, help you understand this better. So by location, so we've got Golgi tendon organ. They're located within the tendon near the muscle tendon junction, and they are in series. Do you remember that term before? In series means in a line. So you've got the muscle, then you've got the Golgi tendon organ, then you've got the tendon, then you've got the bone. So they're in series with each other. The stimulus is increased muscle tension. So if you're squeezing the muscle really hard, you're going to start to turn the Golgi tendon organ on. If it gets turned up too high, then it's going to inhibit tension, so it's going to turn the muscle off so you don't hurt it, and it's going to turn on the opposite muscle so that you move away from that position that could hurt you. And overall effect is that it promotes stretch. So if I'm squeezing my biceps really hard and I'm in danger of hurting them, it's going to turn my biceps off and turn on my triceps, which makes my elbows extend and stretches my biceps. Hopefully that makes sense. Muscle spindle, they are located among muscle fibers, so they are in parallel, like fascia and membrane. So they are in parallel with the muscle fibers running next to them. They are stimulated by muscle length, an increase in muscle length or a stretch. So right, muscle spindles are also called stretch receptors. So they detect stretch, which you imagine if something stretches too much, it could damage it. So their response is to make that thing contract and shorten. So they initiate rapid contraction of a stretched muscle, so they pull it shorter so you don't damage it, and at the same time, they turn off the muscles on the opposite side. Right? So if your quadriceps are stretching too fast, then you want to turn your quadriceps on and turn off your hamstrings, because your hamstrings, if they were to be turned on, they would bend your knee and make your quads stretch again. So you don't want that. So you've got to turn your hamstrings off, turn on your quads, and the overall effect is to inhibit stretch or to put the muscle on slack. You want to shorten the muscle. So you think about the effect of the muscle spindle is to inhibit stretch or to shorten the muscle. Okay, so those are two sensory organs within that affect our joints and joint mobility. They are really, part of the muscle tendon system, but they are, it's a part of that active subsystem. They influence joint mobility, so you want to know about those. Active and passive stretching are ways to increase joint mobility. There are different definitions out there for this, but so for this purposes of this class, we're going to define active stretching as stretching you are creating by contracting your antagonistic muscle. So for example, if you wanted to do an active stretch of your hamstrings, you could lay on your back and contract your hip flexors, right? You'd pull your leg up straight and pull it up high enough until you feel a stretch in your hamstrings. That is an active stretch because you are using the antagonistic muscle, the hip flexor, to stretch the hip extensor. Okay? Whereas a passive stretch is produced by a force other than tension in the antagonist. So usually the passive stretch is something external, like a stretch strap, a partner, something like that, where basically you don't have there's not really any muscle effort on your part. It's something external that's creating the stretch. Okay, so active and passive stretching. We have ballistic and static stretching. Ballistic stretching is kind of out of popularity right now. It's this bouncing kind of type of stretching. If somebody's not trained for it, it's more likely to promote injury. And then static stretching is just holding it. These now we kind of do at the end of workouts. We've seen that, in more explosive athletes, static stretching at the start of a workout can reduce power. So now we tend to do dynamic stretching where you're kind of moving through movements, and then at the end maybe you do static stretching. In yoga, like yoga has a lot of static stretching. So yeah, just the definitions for those. Maybe you've heard of PNF. It stands for proprioceptive neuromuscular facilitation. These are stretching procedures where you're using alternating contraction and relaxation cycles to improve somebody's flexibility and mobility. So you might think of you're doing a partner stretch, you're stretching someone's hamstring, and you go up to where they're tight, and then they kind of push back into you for 5 seconds, and then they relax, and you can stretch a little farther. If you've ever experienced that, that's sort of a PNF type of stretch, where you have this contraction, and then when you let go of the contraction, you can go a little farther. I mean, you can do these on yourself, too. If you had a stretch strap, you could do a contract relaxation. They work well for a lot of people, so if you struggle with flexibility issues, try some of these. Okay? All right, so some pathologies. We're almost to the end here, so just some joint-specific pathologies. The big one that most of us are probably going to think about is osteoarthritis. This is a degenerative disease of that hyaline articular cartilage. We think of it as kind of in terms of different types of arthritis, it's the one that's most mechanical, sort of mechanical wear and tear. It's got genetic factors and things too, but it is does have probably the most mechanical in terms of the different arthritis conditions. And people get pain, swelling, range of motion restrictions, stiffness. You know, if you see it in the hip or the knee, you'll see people limping when it gets really bad. It can be quite painful, right? And the thing with this is that it's not the cartilage that hurts. Cartilage doesn't have any nerve endings. It has no blood supply and no nerve endings. It's the underlying bone. Your bone has a ton of nerve endings. So if you wear the cartilage out and the bones start to come into contact, it's super painful. So that's usually what happening is people are wearing through that thin layer of hyaline cartilage, and then the bones are contacting each other, and that becomes painful. The cause is unknown. It's complex, right? It's we know a lot about this, but it's complex, so they'll still often say that the true cause is unknown. But this one, again, very mechanical, so through whatever your background in movement, fitness professionals, rehab professionals, you can do a lot to help with this type of arthritis. Interestingly, both too little and too much stress seem to promote the development of osteoarthritis. So if you look at people who are completely sedentary, they don't have any stress on their system and they don't promote positive adaptation, and it actually seems to wear out prematurely. On the other side of the spectrum, you take like ultra runners with super high volume running, that can also lead to premature changes in cartilage. So we want to be somewhere in the middle. Now, for instance, like running, recreational running is shown to promote the health of cartilage. So, I mean, it's like everything else in life. There's a moderation kind of concept. So you want to stress your body, but you want to do it in a moderate dose. And if you do that, it helps to keep your tissue healthy. If you don't have any stress and too much, those both can harm your cartilage. So, and this is going to be true for almost every other tissue, musculoskeletal tissue in the body. Here's an image. When you think about osteoarthritis, what they will look for in an x-ray, there's the ABCs, and the C stands for cartilage space. So you can see on this hip, we can see the space here in between the socket, the acetabulum, and the femoral head. There's a little space right there. But on this side, see how the space is gone right here? So if cartilage space is gone, that's one way on an x-ray to identify arthritis. And the hip, again, is a really major one. So if the person has a lot of pain and it's limiting their ability to complete activities in their life, they might have a total hip replacement. Or maybe a hemi replacement where they just replace one side, depending on what it looks like to the surgeon. So that is an image of osteoarthritis. So again, total joint replacement or a hemi replacement where they just do half the joint is an intervention that's used for these. So you replace it with a prosthetic component. It's usually done when the patient can no longer tolerate pain. So usually surgeons will tell people to go as long as they can, and that's often because the prosthetic elements that they put in have a certain lifespan, so you don't want to have to come back and do it again, so they try to have people wait. You can do these, most commonly it's down the knee and the hip. There are also shoulder replacements, elbow, ankle, wrist, thumb, fingers, but mainly you see knee, hip, shoulder, so, and primarily knee. So those ones are out there. Hip, like I said, hip and knee are by far the most common. In 2004, it's a little dated, but there were 234,000 hip replacements in the U.S. and 478,000 knee replacements. So I'm sure most people watching this probably know someone who's had a hip or a knee replacement. Just some images of these. This shows here, part of the hip, the femoral side, so part of the femur, how that could be replaced. Here's, the knee, and then once those things, this is them outside the body, and then what they could look like inside the body. And there's lots of, there's lots of different elements now that they use for joint replacements. So this is just one example, more to just kind of show, just to give you a visual of what it could look like in there. So joint replacement, and then we've got just that hip replacement back in, so helps to restore the arthritis or the cartilage space, and and then the person. These things are amazing. Hip replacements, people do so well with them, and pain's gone, and they're back to doing the things they like to do. So it's really a neat surgery. It's just really great outcomes with that one. So knee replacements are great too, but they're more painful in terms of rehab. Gaining mobility back after knee replacement is often uncomfortable for people. So the hip replacement's much easier most of the time. Okay, rheumatoid arthritis. Another arthritic condition. This one is inflammation of the lining of the joint and synovium, and this can lead to permanent damage. This one's different than osteoarthritis. It's more of an autoimmune disorder. People can have it when they're young too. We can see juvenile rheumatoid arthritis. This one's tough because your own immune system is eating away at the joints, and so a lot of it is trying to help people through exercise to help preserve the joint and just keep it as healthy as you can, but it's a tough one. It goes through 3 stages. We have a swelling of the synovial lining, so you see redness, warmth, stiffness, just like osteoarthritis in a way. And then we see this rapid division and growth of cells, which causes the synovium inside the joint to thicken. And then the inflamed cells release enzymes that digest the bone and cartilage. So again, it's an autoimmune disorder where your own immune system is recognizing your cells as invaders and digesting them. So basically, if you digest the bone and cartilage, the joint loses stability, and it's really, you're losing that passive subsystem. So the osteoligamentous system is being digested, and people lose a lot of stability. And one of the hallmark signs I'll show here in a second, but how it affects the joints in the hands. This can affect 1.3 million Americans. The cause is unknown, again, because of how complex it is, but it's classified as an autoimmune disorder. It's a chronic disease. People have flares in it, so they'll be good for a little while and they'll have flares. So in terms of rehab, sometimes when somebody's having a flare, we won't want to push their body and train them. We'll wait till the flare's over and then work on strengthening the area and things and improving mobility. It's a systemic disease, so it can affect other organs, not just the musculoskeletal system. And there's no cure for it, unfortunately. But medications, exercise. A lot of rehab is focused on protecting the joint strategies, exercises, movements to help protect the joint, so that you can slow the disease process. This is a hallmark sign of rheumatoid arthritis. It's called ulnar drift. It basically means you might see these in individuals, your grandparents who have it, or if you ever work in a nursing home, you see this from time to time. But the fingers drift towards the ulna on the outside of the wrist. So as the joint is eaten away, these metacarpal joints are eaten away, and you lose stability in the fingers will drift. They kind of fall to the side because they've lost the stability in the bone and cartilage here. So they call this ulnar drift, and it's a hallmark sign of rheumatoid arthritis. Okay, last thing here is just joint dislocation and subluxation. This maybe is the thing you think about even more with joint injuries. I've just got a couple of images here. One is a hip dislocation, which again, you don't see these nearly as much as shoulder dislocations, but sometimes they happen in car accidents where someone's knees hit the dashboard and it shoves their hip out the back of the socket. Sometimes that can happen. This is a big toe dislocation, so you can see here, a dislocation is a situation where you lose full contact between the bony surface. I mean, look at that. This person's toe has popped fully off the metacarpal, so not a good day. But, it's lost complete contact, so that's a dislocation. This is a dislocation. A subluxation is where you only lose partial contact, and usually subluxations will go back on their own. Maybe you've experienced this in your shoulder. I've had this happen before. You're in an activity and it kind of feels like it slips apart but then just pulls back again. A dislocation, on the other hand, usually you have to go to the emergency room and a physician has to reduce the dislocation. So they have to pull the joints back together through different techniques. Some people who have had lots of shoulder dislocations can pop theirs back on their own, but usually that only happens after the joints really stability has been majorly compromised and they're able to use their neuromuscular system to pull it back. So dislocation, subluxation, and that takes us to the end. So that is a bit about skeletal articulations. Next time we're going to jump into the spine, so I will see you then. Bye.